Okay, good morning. I think we'll go ahead and get started. And I just wanted to introduce to you our speaker today, who is Dr. Rola Abu-Arja, and she is visiting us from Nationwide Children's Hospital. And just to give you a little bit of her background and who she is, she went to medical school at the University of Jordan, and then did pediatric residency at Mount Sinai, and then did her hematology, oncology, and bone marrow transplant fellowships at the University of Iowa, and then stayed on there as a faculty member for 3 years as an assistant professor. Moved on to Rainbow Babies for a while, then on to Cleveland Clinic, and then since 2014 has been the clinical director of bone marrow transplant at Nationwide Children's. She's involved in running clinical trials there. She's the clinical trial principal investigator for a haploidentical transplant using graft manipulation for leukemia, and also in charge of the viral cytotoxic T-cell trials for viral illnesses there. And recently has become what's referred to as a FACT inspector, but FACT is a group of people that give accreditation to bone marrow transplant programs. And so now she's going to just talk to us about an overview of bone marrow transplant today, but we're really excited to have her here with us today, and hopefully you'll enjoy her talk and afterwards have a chance to get to know her a little bit. So thank you.
All right, thank you very much for the great introduction and for having me in Orlando. I come to Orlando all the time at just visiting for Disney and Universal, and now I'm seeing the actual city and the hospital. And so I'm going to talk a little bit about hematopoietic cell transplant. I think people used to call it bone marrow transplant back in the day because of, and we'll talk how it evolved over the years, but right now the term is hematopoietic cell transplant or blood and marrow transplant because it's not just a bone marrow transplant anymore. So we'll talk about when it started, what it is, how it's done, and why we do it, and where are we going from there. So first I'll start with the case, and I'll run over 5 cases, just random, that maybe someday you will get exposed to it at some point in your career. I know as in general pediatrics, or before even when I was in medical school, I've never heard of bone marrow transplant. I didn't know what it was. As residents, you don't really have any service on bone marrow transplant, so you really know nothing about it. And I don't expect a lot of people to understand until I started my HEMONC fellowship on my first day on bone marrow transplant service, when I'm like, what is this? Oh my God, this is very highly complex. And it is, but I'll try to make it as simple as possible for people to understand. So the first case, you're in your general clinic seeing a 12-year-old healthy male who has sickle cell trait, and he's here for a well-child visit, and your mom tells you that his brother, who has sickle cell disease, is being considered for a bone marrow transplant. And this brother, the patient that you're seeing, he's actually found to be a match. So she has so many questions to you. She hasn't yet talked to the transplant team, so she's asking you, what do you know about this? What is bone marrow transplant donation involved? Is it surgery? Is it dangerous? Is it painful? What do they remove actually pieces of the bone? Is it a long recovery? Do we have to pay extra and put him on his health insurance? What does it involve? Can I be a donor instead? Is it better for me to donate? Can someone else donate rather than my healthy son? Then you have a second case, and we'll answer these questions as we go through, but we'll start with the first. You have a second case, a well-child visit. You're there seeing a 12-month-old who you're seeing him for the first time because he just moved from another state, and you notice that his head circumference is more than 97th percentile. He has history of poor feeding, micrognathia at 4 months, bilateral hernia, recurrent infection, bilateral E-tubes at 7 months, and he had developmental delay. And been having therapies. So you do an exam, and he has these coarse facial features, large tongue, has a palpable liver, and basic kyphosis. So you suspect Hurler syndrome or Mucopolysaccharidosis, and you send the Mucopolysaccharidosis screen, and you notice that it was positive. So you tell mom, we're going to refer you to genetics and possibly a bone marrow transplant. This is what we know is the treatment for it. And she has all these questions. What is this? Why is transplant going to treat this disease that is, I thought bone marrow transplant is just for cancer. What does this have to do with this? Moving on for the third case, you get a call from the Department of Health about an abnormal newborn screen. You saw this infant about 2 days ago, and his newborn screen was positive for severe combined immunodeficiency. And we call the mom, who's frantic, just had a baby, and she tell her, well, you have an abnormal screen, and we think that your child has severe combined immunodeficiency. Mom freaks out and says, what do I do? Where do I go from there? Do I need to do anything? We tell her you have to go to the immunology and possibly the bone marrow transplant team. Moving forward for the case 4, then you're seeing a 4-year-old for a well visit, and the mom is 25 weeks pregnant. And she says, asking you, I'm thinking of saving the umbilical cord blood. I heard that that's useful for transplant. Maybe I'll use it for my child. What are the pros and cons for saving my cord blood? Is it something that I need? I heard it's expensive. Can you tell me a little bit about it? So, she asked, what is cord blood? Are they stem cells? Are they used today? How do we store it? How much does it cost? Is it dangerous to collect it? Do I have any other choices, or do I even need it or not? And the last case I'm talking about, and then I'll try to combine all this together, is you're seeing a 10-year-old male who actually 15 months ago was diagnosed with aplastic anemia and was treated with a matched unrelated bone marrow transplant. And now he's off all his medication, and he is here to reestablish care at your general clinic. And you're like, okay, well, how do I take care of a patient who had just had a bone marrow transplant about 15 months ago? Do I really do anything? Is he the same as other people? Do I have to do anything extra? So there's a lot of questions that mom tells you, do I need to still see the bone marrow transplant team? Do I follow up with you? She tells you that she's still following up with a long-term follow-up clinic, but there are some things that you need to take care of because he had had a bone marrow transplant. So basically what I'm going to try to answer, like we talked about, is when did bone marrow transplant or hematopoietic transplant started, and what it is, how do we find donors, and what do we need to do, what do we need to know about it, and where do we go from here. So how it all began, really, we started with this field a long time ago, in 1868, when Newman and Pizarro reported that blood cells of mammals were actually produced in the bone marrow. That's the first discovery back more than 100 years ago, when they discovered that bone marrow is actually a factor where the blood is being produced. But and it actually goes through cavity from the bone marrow and then goes into your blood and formulates your blood. But really, no other research has done after that, and people kind of just left it there until a disaster happens, which is World War II, when you had the atomic bomb at Hiroshima and Nagasaki, and that's when really almost a month after the bombing happened, patients who didn't die from the actual bomb started having this disease where they started losing their hair and they're losing their blood cells. So they became aplastic, and that's when they realized that the effect of radiation it can really affect the bone marrow, and the bone marrow is what makes the blood system, and that's where the research really triggered after that. So they started doing some mice experiments trying to understand more the field of bone marrow transplant and how it is, and they found if they radiate mice, the mice die, and they will lose all their blood cells, and they will just die from aplasia. Then they thought if they actually shield the mouse's spleen and do radiation, they are protected. So they figured, okay, if these bone marrow cells or stem cells, they didn't know it's stem cells at the time, if they're replicating and they are protected, if we can shield them from the radiation. Then they did more experiments and thought, okay, if we actually do radiation and then infuse other mice's stem cells or spleen cells at the time, they found out that these mice were protected. So that's sort of the first idea of, okay, these cells can actually go from one person to another, and they can regraft, and they can repopulate someone else's bone marrow after it's been destroyed with radiation. At the time, radiation was the only thing that's thought to affect the bone marrow. So they thought, okay, well, if we can actually get rid of radiation, get rid of bone marrow cells, we know that leukemia cells also grow in the bone marrow. So if we get rid of those bone marrow cells, we probably can get rid of leukemia cells. So that's where the concept of radiation in the treatment of leukemia had started. And thought, okay, if we can get rid of leukemia and stem cells, then if we infuse somebody else's healthy stem cells in there, we can cure leukemia. It wasn't that easy, but that's a thought, and that was really a smart thought. So it started really by Donald Thomas, who actually ended up getting a Nobel Prize in 1990. In 1957, he had the first infusion of marrow into human. It wasn't successful at the time, but he had the idea because, he gave radiation and then ended up using bone marrow from a sibling and infused it, and the patient still ended up dying from leukemia relapse. He has done so many other transplants from the 1950 to 60. Over 200 transplants were done, but really there were no success. And people were discouraged that, there's so many challenges, this is not working. They're discovering diseases like, there's something called graft versus host, and all these diseases that are not fully understood. Patients' leukemia are coming back, their rejection, so many different challenges that people didn't understand. And they didn't understand, actually, that you really need to find a donor, and the donor finding process is not just you get one and you transplant it to another. So the challenges is you try to find a donor who's suitable. You have to understand HLA typing, which I'll talk a little bit about that. And then supportive care at the time in the 50s and 60s was not as good as it is now, where we have transfusions, antibiotics, ICU, et cetera, surgeries. And then they didn't understand the concept of graft versus host and host versus graft. So this is a concept that was not understood. And then they've seen a lot of relapse because of the poor understanding of this whole thing. But about, almost 100 years later after that first discovery, but in 1963, this Dr. Kyle, who was actually a mentee of Dr. L. Donald Thomas, was in Mayo Clinic, and he had a patient with aplastic anemia that he noticed. He was seeing her in the room and noticed that she was very cushy-noid, but he saw her sister who looked identical to her, and he asked, if she was an identical sister. She said, yes, she is an identical twin, and he suggested, why don't we do a bone marrow transplant? She's aplastic. Why don't we do a bone marrow transplant from the identical sister from the twin to her identical sister? And he did, and that transplant was successful, and that was the first successful syngeneic transplant. Syngeneic means a twin-to-twin transplant. So basically, you're just using the exact same, because they have the exact same stem cells on both sides. Then in 1968, where the first real successful allogeneic transplant happened, and that's when it was from a sibling, but he was not an identical twin, and that patient had congenital immunodeficiency and was born with this immune deficiency, and he had his mom, basically all the male in her families, about 11 of them, died from this congenital immunodeficiency. And when the baby boy was born, he has 4 sisters, and the doctors at the time said, let's check. And that's when the concept of HLA typing had kind of emerged. And they said, let's check the sister. And they found one of them that was a match. And they used her marrow, and the kid is alive and well as today. Then in 1973, the first unrelated bone marrow transplant had started. And it was in London, actually, where a patient who was diagnosed with chronic granulomatous disease. And you see, most of these diseases that started successful are not leukemia. They were all non-malignant disorders. So the person had CGD, and they couldn't find a match, and he was very sick. And the mom put in the ads in the newspaper and thinking, like, can you come in and get typed, and let's find out if there is any match. And it became a big thing in London at the time. In the 70s, a lot of people went in and started testing for it, and they actually found a match. And he got a bone marrow transplant from the first unrelated donor. And at that time, another mom who had a son with Wiskott-Aldrich syndrome, she did the same thing, but unfortunately she couldn't find a match to her son, but she created the Anthony Nolan Foundation, which is basically the equivalent of the Be the Match that we have here in the United States. So it matches people around in the United Kingdom. Moving forward from the 1970s and above, bone marrow transplant takes off, and now we're more and more getting to know a lot of the stuff. So after that, in the 80s and beyond, lots of knowledge has happened. And that's what I say, like, when I did my medical school in 1992, like, we really didn't know a lot about transplant at the time. And those are the things that we started learning about: indications for transplants, what is human leukocyte antigen, what's the role of it in transplant, that we use chemotherapy instead of radiation, because radiation was the one that's used back in the day, and nowadays we're more understanding that we don't really need to use radiation because of all the effects that it had on children. We understood graft versus host disease, and also, like, the supportive care with time has improved with infectious diseases and antibiotics and antifungal, antiviral, all that stuff that was really like challenging during that time. We understood that we need more donors because only 1 in 4, 25% chance that you would have a sibling donor, so we knew that we needed to increase the pool of unrelated donors out there. And the discovery of the umbilical cord blood had also emerged in the late 80s. Then the field of autologous, which is transplant from your own self, had emerged. And then lastly, just in the last 10 years, were haploidentical transplant, which is basically a transplant from a half-match parent or a sibling or a son in the adult world had become the next thing. There's still a lot of challenges, like the cost of transplant. It costs almost $500,000 to $1 million to actually do a transplant, so it's still very expensive. Getting a cord unit costs about $30,000 per cord, so it's very costly, and it's really a treatment or a procedure can really be done in developed countries. A lot of the other poor countries cannot afford doing a stem cell transplant. And we have to deal now with the long-term effects. Now we've done all these transplants in the 80s and 90s, we're starting to see what are the long-term effects of what we've done. Moving on with the field in 1984, there was a marked transplant, because that's where the indication actually increased. We're realizing that we could treat a lot of things with transplant, not just leukemia, not just immune deficiencies or aplastic anemia. There was a New England Journal of Medicine article where a patient who had sickle cell disease and had leukemia was transplanted really for the leukemia, but they found out that his sickle cell disease actually got cured too. So that's where, okay, well, we can actually cure sickle cell disease, we can cure thalassemia. There's other diseases that could be treated with bone marrow transplant rather than just the malignancies that we all think, when people think of bone marrow transplant, think leukemia or lymphomas. So we knew we needed more donors, and that's when the National Donor Bone Marrow Program had started. The US government had established funds to create this registry in the 1980s. And it's still headquartered in Minnesota, Minneapolis, and to this day, almost more than 12 to 2,000 search requests have been done through the NMDP, and it facilitates so many transplants every month. And it combines all the registries all around the country, all around the world, actually, not just in the United States. So now we have more options. There's lots of options to getting donors out there and getting patients cured. So now we talked about how we got to where we got. Now we talk what is the hematopoietic cell and how does it really work and how does it really help and what does it mean? So, a stem cell is a cell that can grow and replicate and make more of itself, and it also can differentiate to what it is needed to be. So you can put a stem cell somewhere and it can just keep making itself, or grow into different things like lymphocytes, monocytes, red blood cells, etc. So it has 3 characters that are very important to remember are a stem cell. It has to have the potential for self-renewal, and it can differentiate into different things. And it has the ability to grow in another environment, we call it engraftment, if you provide the right circumstances. So you cannot just get one stem cell, you say, okay, this hematopoietic cell you said can engraft anywhere. You can engraft it anywhere, but you have to have the good surround sound, basically having a way of, things to defend it, things to make sure that it's not rejected. So there's so much surround sound that we have to think about when we're trying to engraft a cell or make it grow in another place. And that's basically what a transplant. It was trying to engraft these hematopoietic cells from one person, moving it from one to another. So I'm going back to the basics a little bit. I know like people don't like the basics, but it's just this slide I think is the most important slide in bone marrow transplant or stem cell transplant, because what it is like you have that hematopoietic cell that originates first in the fetal liver, then in the fetal blood, and then it starts to grow in the bone marrow. That hematopoietic is the one that has the ability to self-renew. Then it becomes into a progenitor cell, and it has the ability to mitotic and differentiate, and then it has the ability to differentiate as well. So it differentiates depending on the needs of the body. So if you need more lymphocytes, it will become lymphocyte progenitor. If you need more red blood cells, it becomes more myeloid. So there's two different parts that it grows to. Is the committed lymphocyte progenitor, which grows into your T cells, B cells, and NK cells. And it also grows into the myeloid progenitor that will eventually give on your neutrophils, your megakaryocytes that make platelets, and your red cell precursors that are going to make red cells. So basically, this cell is capable of making your blood system and is capable of making your immune system. So any disease can affect any of this. You could potentially cure it with a stem cell transplant. It's using the right circumstances. So where do we get it? That's where the term bone marrow transplant came from. But everybody thinks that you can get it only from the bone marrow because that's where all stem cells, and true, all stem cells, we used to get them only from the bone marrow. But now we have newer areas like the peripheral blood stem cells. We can actually now fool the bone marrow by stimulating it the right way. We can actually trigger production more and more of the stem cells that they actually go into the peripheral blood system, and we can capture them from there. And we also discovered that cord blood is very rich in stem cells. So donation is not scary, and we're going to try to answer the first mom's question by saying what are the different donation methods. So how do we get the bone marrow from a donor? And it's called a bone marrow harvest, and it really requires using two of these needles. It looks scary, it looks like you're in the OR and you're actually wearing the whole, surgery stuff and under sterile procedures, but you get anesthesia. You can get full anesthesia or spinal block, but most of kids, at least, they use full anesthesia. And you use two needles, and you typically need two harvesters, one on each side of your posterior iliac crest, and you go in and you just put that needle in and you basically aspirate the marrow. And you aspirate slowly until you get a certain amount of cells that you have the nerve there, you're aspirating from each side, and you're putting it in that bag and calculating how much you are getting. Halfway through, you send the sample to the lab. They tell you you have this number of stem cells in that. You should be good to go for the donor. If not, you keep collecting more. There's a limit. Obviously, you cannot collect as much as you can. You can collect up to 20 ml per kilo for the donor size. And then at that time, most patients, donors, they actually do really well. You end up getting a bag like this right here, and that is bag, I like to call it, the bag of gold. Like, this is a very precious thing that's going to save somebody's life. And you take that bag and you take it to the stem cell facility where it gets stored or given infusion to the patient on the same day, or transported to another country, depending on where you need it. The patient who is a donor really, well, most of them are, especially if they were kid donating to a kid, they're running around the same day, or they might or might not develop anemia after. We check their hemoglobin 24 hours after, and they're typically fine. Adult donors probably will need 24 to 48 hours time to recovery, but it's just 2 points of pain on the back and they're fine. The reason we need two harvesters is just it's a very labor-intensive. It's tiring trying to get that. So, one time I was in the OR and my nurse practitioner who was harvesting with me passed out, so I had to do it all by myself. So you need to have two people at least for a backup too. So yeah, I had tennis elbow for a whole month after that, having to collect 1,000 ml. So then we're moving on to the peripheral blood stem cells. And that's like now where a lot of the adults using. They're not using bone marrow harvest because of the procedure, and you're limited of how much you can get actually from a bone marrow harvest, especially if you're getting from a child who's small to an adult, or if you're getting from a smaller child to a bigger child. So it gets harder. So they discovered this new method of collecting it through the peripheral blood. And what they do is they stimulate the bone marrow by giving Neupogen or GCSF or granulocyte stimulating factor. And you give it for 4 to 5 days, that you trigger the production of stem cells so much that they are spilled into your peripheral blood. And then you hook the patient on a machine, or the donor on a machine, and what it is, it's basically a fast centrifuge where the blood goes from one area, it comes out from the patient, goes into the machine, it filters, takes all the white cells, and brings the red blood cells and the platelets and the plasma back to the patient. And the circuit takes about 3 to 4 hours. You keep going that, and you take the bag of cells that has nucleated cells, so it has everything nucleated, not necessarily just stem cells. It has lymphocytes and other things, and then you collect it, you count. Most of the time you can get a lot more using this procedure than you do with actual bone marrow harvest. But there are risks that because you get more T cells in this one, you have a higher risk to develop graft versus host disease. But this is the method that we use for adult, and it's the method used if you're collecting your own stem cells for autologous transplant, and we'll talk about it in a minute. Then in the late 80s, when the first umbilical cord blood transplant happened, and it really didn't happen in the U.S., but it was the idea had come from the U.S., because there was a patient who has Fanconi's anemia and was heard about the bone marrow transplant and didn't have any donors, and was seen in Duke by Dr. Wines-Kilsbergs, and she had found that the mom was pregnant and thought, okay, well, maybe we can use the cord from your unborn baby to transplant this child with Fanconi's anemia. So since it couldn't be done in the United States because of all the regulations, the patient flew to France, and they were able to do the transplant over there, and that was a very successful cord blood transplant. And then from there on, the field of cord blood transplant had started. The cool thing about cord blood transplant is that it's really easy to collect. It's not really risky to anybody. It's after the baby's born, you actually get the placenta and you just milk the cord and put it in a bag. And the units are stored immediately. They're frozen and available when needed. So it's really an easy process to collect it. And also, like, the risks of transplants for graft versus host disease and others, and the matching is not required as much as if you're getting from somebody who's an older person. Because these cells that are in the cord, they're very primitive. They haven't been exposed to anything, so they're naive. There's a lot of naive T cells that really, when you infuse them, they're less likely to attack and cause the graft versus host or other things. So it's very, a lot of the time people with children, they like to use cord blood transplant because it has less side effects, and it also the size is small and the kids are small. So it's better for them. But the adults don't really like to use it because it's a really smaller size for the big adult size. So the question that I get asked a lot, and a lot of people might get asked too, like if they're just physicians, is do I store my own cord blood or not? And I myself had that question too. When I was pregnant in my fellowship, I went to my bone marrow transplant mentor and I said, do you think I should store my cord blood? And we really went through over the pros and cons, and I ended up actually donating it to research. But I think we'll talk about the pros and cons. So I think the pros is maybe you would need it in the future if you get cancer, and making it is easy. So those are the two, I think, the only pros for it right now. But the cons, it's really very expensive to store it. In order to put it in a private bank, it costs about $3,000 to $4,000, and you have to keep this maintenance fee every year. And the chances of you needing your own cord blood in the future is really small. And it's really, even if you do get cancer, you're not going to use your own cord blood to treat it, because most of the time you really need you need the cells from another person to try to fight your cancer, because you need the immunity from another person to fight cancer rather than your own. And if you have a genetic disorder that you're trying to treat, you're not going to use your own cord blood that are already genetically the same thing. So maybe in the future there's use for it in treating like MS and neurological, but we're still not there yet, and the research is still in the primitive area. So maybe in the future there's going to be need for it, but as we know now, there is nothing that I would consider using my own cord blood for myself in the future, other than maybe if there was a radiation atomic bomb and you have it saved, yeah, that would be great. But other than that, I don't think there is. So I think I always give the advice is that if you really want to have it, you don't want to throw that bag of stem cells, donate it, because it's there, and if you ever need it, it's going to be in the registry, and you can't find it. You won't know it's yours, but it's there, and you'll know that it's available. So, or you can just threaten your kids and tell them you'll unfreeze their stem cells if they don't behave. So I just checked for Ohio, for Florida, to see what you guys have for donation. And there's a public bank here that people can donate, and those are the centers where cord blood can be donated. And I saw that your hospital here is one of those. So you just have to talk to your OB and say, hey, I want to collect my cord at the time, and I want to donate it to the public cord bank. And usually this picture here is basically how the cord bank is stored, and there's usually this little segment that they keep it outside that you can actually take and test for other things. So if you're when I use this sample, they actually type it before they put it in, and they make sure that the typing is in the registry. But then if you want to test it for, let's say, does this cord unit has Hurler syndrome in it, or does it have this? I'm using it for the treatment of this thing. Can I test it before I transplant the patient? There's always a little bit of sample that you can take to test before you do a transplant. So I talked a little bit about, most of the time about this transplant from one person to another, transplant from one person to another, but there is also this form of auto transplant where you basically get your own stem cells. And that field has grown also since the 80s to the 90s. And it's more now, it's used a lot in adults and in kids in the case of brain tumors and in the case of neuroblastomas. And what it is basically is you're not really treating the bone marrow or the stem cells. You're not using that for anything. What you're doing is you want to be able to give these kids with brain tumors high amount of chemotherapy that could penetrate their blood-brain barrier and, attack the cancer, or the neuroblastoma patients. You want to give them high doses of chemotherapy that you couldn't give, because if you do, they're going to suppress their stem cells and you possibly will kill the stem cells completely. And then they will have longer time to recover, and they will not be able to repopulate their blood system. And they will have infections and high incidence of mortality and morbidity. So they thought, okay, how about before we actually give them the chemotherapy, we can go ahead, collect their stem cells using that harvest procedure that I showed you, take the bags, put them in the freezer, and store them. And then now, give them as high dose of chemotherapy as we can, and then as soon as we give the chemotherapy, go get the bag, thaw it, and give it back to them. And then that way, those cells, their own cells, they go back and they grow and they make their blood system faster. So then that way you improve their recovery period, and they don't get as sick as if you didn't give them their stem cells. So this is very common, at least in our institution, for brain tumors, where they get multiple high doses of chemotherapy, and we follow them by autologous, and we call it a stem cell rescue. We rescue them with their own stem cells. So that's where the autologous transplant is, and it has less complication because you're using your own. So there's no fighting, there's no two different things, you don't need to type anything. It's your own cells, you just take it back. The allogeneic transplant, like we talked about, it's cells from one person to the other. So if you think about it, you're trying to take this stem cell from one person and put it in another person. You need to think about all the different things that you have to prepare for that stem cell to grow. You can't just take it and grow it. You have to prepare the body to accept it. You have to give it some cells to fight for it. Because if you just take one stem cell and put it from one person to another, immediately that donor, that patient is going to reject it because they're like, this is not mine. This is not my stem cell. So what you really need to do is you have to prepare the patient who you're trying to do a transplant for to receive those cells. So you have to empty their bone marrow completely so you have space for these cells to come. And you have to suppress their immune system so they don't reject it. But at the same time, you're creating somebody who has no blood system, no bone marrow, and no immune system. And you're just giving them these stem cells along with the T cells that are just going to be like, okay, this has no defense whatsoever, and you give stem cells with T cells that are going to attack and think, okay, well, this is not my body either. So that's when the graft, which is the new cells, can go and attack the body and cause the graft versus host disease. So that's the big challenge of allotransplant, and that's why a lot of us, in the transplant field, try to figure ways of how can we protect the patient from the graft versus host disease. Sometimes we do need a little bit because you think, okay, if that graft is attacking the host, maybe it attacks the leukemia as well, but it's a balance. We want to try to make sure that it's not. So the different kinds, you get it from the same twin. We don't really use it unless if you're on a plastic anemia maybe, but in general we don't use it in leukemia because it's basically as if you're using your own cells. And the relapse rates are really high if you use a syngeneic or identical twin. But sibling is still considered the gold standard. If you have a sibling, that's the best way. You're genetically matched and you're phenotypically matched because you're getting your terms from both parents and you're from the same genetic background. But if it fails, there's the unrelated donors that you can get from the registry, or nowadays we can get from the parents, which I'll talk about in a bit. And of course the umbilical cord. So, the diseases for bone marrow transplant or stem cell transplant had increased over the years, and we started initially thinking of leukemias and then immune deficiencies, but it's a lot of malignant diseases are used, we use transplant for, but in children, the field is growing less and less where we need transplant for malignant disorders. In adults, it's growing. In kids, it's less, because we're discovering a lot of newer things in kids that we can actually treat leukemia, and CMLs and AMLs, where, for example, like in the early 2000s when I was in my fellowship, every patient who had AML, who had a matched sibling donor, will go to a bone marrow transplant. Right now, AML don't necessarily go to transplant. They actually get chemotherapy and they're fine, unless they have certain genetic that makes them high risk, or if they don't respond to chemotherapy, or if they're relapsed or refractory. So the need for transplant in malignancy for children is less than it was back in the 90s and 2000. Also, like CML, for example, chronic myelogenous leukemia, transplant was the only curative for this. But then with the discovery of Gleevec or tyrosine kinase inhibitors, now we can give a pill and you can cure CML. So you really don't need to do a bone marrow transplant and expose them through the whole thing for that. So the field is changing in the malignancies. In adults, it's still growing. Multiple myeloma, they're using it for AML, leukemias. They're still needing a lot more there than we do in pediatrics. So actually, in our pediatric bone marrow transplant unit, we see more non-malignant disorder than malignant disorder. So the non-malignant disorders, when I showed you that flow chart of all the different, where the stem cells make, so if you think about it, anything that is made down there can be treated with a transplant. So if you have a red cell disorder, like hemoglobinopathy, sickle cell, thalassemia, congenital erythropoietic anemia, anything that affects the red cell, you can really replace a new stem cell and create and cure that disease. If you have bone marrow failure, you're not making anything because of either inherited bone marrow disorder, like a Fanconi's anemia, Shwachman-Diamond, any of these, pure red cell aplasia, all these things can be treated with a bone marrow transplant. Also immune deficiencies, which obviously that was the first thing that was used, and then metabolic disorders, and that's a field that, we talked a little bit about a patient with Hurler syndrome, but you're like, how is Hurler syndrome being treated with a bone marrow transplant? Well, Hurler syndrome is because of the lack of enzyme that is made in the white cells. So if you actually give them a transplant to make the white cells, then they start making the enzyme and we cure the disease that's usually fatal. And then HLH, which is another, or histiocytic diseases that also are treated. So this is just a slide of, just thinking of the stem cell and all the different areas. So if you don't have the lymphoid, you have SCID, you're treated with that. If you don't have B cells, like patients with X-linked agammaglobulinemia, Bruton's disease, even though they don't use it, you do use a transplant for. We had a patient who had AML and Bruton's disease. We transplanted him for the AML. His Bruton disease is gone. So because he had a B cell disorder, and that you can treat it with a transplant as well. Any other enzyme diseases, osteopetrosis, Krabbe's disease, chronic granulomatous disease where it affects the neutrophils, hemoglobinopathies like sickle cell and thalassemias, and Glanzmann thrombocythemia, congenital amegakaryocytic thrombocytopenia. All these diseases can be treated with a transplant. So you just kind of find the right combination of treatment and the donor to do it. With the introduction of newborn screen, finally a patient like that bubble boy will actually get treated immediately now. They don't have to wait until they get infections. And it's really cool that now all the United States almost are doing the newborn screen. In Ohio, we started in 2013. And since the newborn screen, we've had about 4 patients in our center that were diagnosed with a newborn screen with SCIDs. They came in on day 7. We type them, we type their family, and once we find 2 of those we find a matched sibling, we did a transplant within 2 weeks. And the patients did fine. Before that, when I was a fellow, before the newborn screen, we would see patients 6 months, recurrent infections. Now they have pneumonias and they have PCP and they have CMV, and then you're trying to transplant them, and then the morbidity is high because they've already had so many infections. So transplanting for kids early made a huge difference, and the newborn screen made a huge difference. So it's really cool that Florida is one of the first ones to actually introduce it. Metabolic diseases also, the newborn screen is also expanding into metabolic diseases. I think Hurler is going to be the next one to be they're pushing forward, at least in Ohio, to be in the newborn screen as well, because you can really make a difference if you transplant these kids early. If you transplant them before 17 months of age, their outcomes are going to be as good as if they were normal. Compared to if you didn't transplant them, they die within 10 years and they have severe developmental delay and cognitive abnormalities. Krabbe's disease is another disorder now just added to the newborn screen in Ohio, and it's also a neurological disorder that causes demyelination, and it's a lack of enzyme that is devastating. Kids by 6 months, they're seizures, they have developmental delay, and they die in the first decade of life. And now we've just transplanted a kid on the newborn screen for Krabbe's, doing fine already 6 months out from transplant, and no neurological illness. So just to kind of like go over a little bit, because we talked about that case in the beginning, Hurler syndrome is the most severe form of Mucopolysaccharidosis type 1, and this is sort of my passion. I love treating patients with Hurler, and they lack the enzyme, the L-aridinase. And although there is an actual enzyme replacement therapy, and you would think, okay, well, the patients can get enzyme replacement once a week and be done, but unfortunately that enzyme replacement cannot cross the blood-brain barrier. So even though you can correct everything else that they have with the enzyme, you cannot cross the blood-brain barrier, and they will have neurological manifestations, and they will be devastated. So what you do, those patients, they progress, and with a transplant, you really now created a cell that will just make the enzyme for them, and they will stop the accumulation of the mucopolysaccharides, causing to the devastation. It's still not 100% curative. They still, especially if they're transplanted late, they still do have some of the orthopedic manifestations that persist, but everything else, cognitively, walking, developmental, they still need a lot of follow-up, but at least they're actually considered somewhat normal. So the transplant process is very complex, and it requires a lot of preparation, so we make it into 3 different sections with the pre-transplant, where it requires so much planning, and the peri-transplant period, where it's the acute phase, where the management is very complex, and that's when you require a HEPA filtered unit and a very safe bone marrow transplant that is free of infections, etc. And then the post-transplant period is also very laborsome. So this is just our program, and I just wanted to kind of put it in there, not because I'm trying to promote it, but it's just to say, like, this is how many people we have, and we do about 60 transplants a year. And this is just to take care of the transplant patients. We have all these physicians, a dedicated pharmacist, 6 nurse practitioners, a dedicated social worker, a psychologist, a palliative care attending, and 3 coordinators to just arrange for the coordination of care and managing these patients. So it's really it requires a lot of work, and it requires a lot of services. So these coordinators that you saw is what they help us find a donor. And really, we talked about how we find donors, but it's using this HLA. So it's not blood typing. And I get this all the time. Well, we have the same blood type. Can we just be donors? And we're both A. And it's a really highly more complex process than blood typing, and it's using the HLA. So the HLA is the major histocompatibility complex, which is MHC. And it's the genetic region that's containing the HLA genes, which is at the short arm of chromosome 6. And it encodes all these antigens that are presented on all our body. And what tells the body that this is us and not to attack. So you have class 1 and class 2 antigens. Class 1 antigens are on every single cell of our body, and class 2 antigens are our immune cells. So if you have those, then your body's not going to reject itself. So if you match it, you would hopefully not reject the transplant. So the way we inherit HLA is just like anything else. We get 1 HLA from a mother, 1 from our father. So every patient is half matched to their parents. Nowadays, with the introduction of DNA, back in the day, it used to be you do a blood test, you look for the antigens, and you see if they have it or not have it. And nowadays, it's very easy DNA. You just swab the kid, and you send it in 48 hours. You know if he's a match or not by DNA. And of course, finding a match is easy. Like we said, in the sibling is a 25% chance, but if you can't find it, you go into that registry we talked about. Just to kind of give you an idea of if you're Caucasian, this is the opposite of what it looks like. If you're a Caucasian, 98% chance to find a match. But as you move in race, it gets less and less. And maybe because there's less people from other ethnic backgrounds are in the registry, probably. So it's really easy to find if you're Caucasian. It's almost impossible to find if you're mixed racial or if you're African American. So that's where the problem comes for sickle cell disease patients. That's why we have to discover other ways to transplant them, because we can't find donors for them. we always encourage people to go, especially if you're a minority, to go on the registry and donate. But once we find the donor, we think of a lot of other things too. You know, the size. A child can donate to a child. So it's the misconception you have to be 18 to donate. You have to be 18 to be on the registry. But if your brother is sick and you're a 4-year-old, you can donate. You can donate even if you're a 1-year-old. But we also worry about the size. We will always want a male donor, not because we're sexist or anything, but it's just because females tend, especially if they have a lot of children, they develop alloantibodies and they can cause rejection. So we'd rather have a male donor, but that's not, we're not set on that. The ABO is not important. We look at it, but it's not. If you're not the same ABO, doesn't matter. We take the red cells out and we do a transplant without the red cells. So if it is the same, we just give everything. But we don't worry about ABO at all in the transplant. One of the things that we worry about the most is the CMV virus, because the CMV virus grows in the white cells, and it's one of those that it's in your body all the time, especially if you had it at some point. And once you get a transplant, you get chemo or radiation, it's fluoride in your system, and it can cause disease, and it's really hard to treat. And we like younger, so if you're in the age of 18 to 40, we want you to be on the registry. If you're more than 40, you're considered old, but you can still be donating. And the reason why is because we want you to pass your health screening test to donate. So I've had a patient who's ready to go to transplant. We had only a 47-year-old donor, and then like a week before, she didn't pass her health screening exam, and we had to cancel everything, and we had to look again. So if you're 18 or 20s, you're likely to be healthy. But sadly, not everybody finds a match. So that's when we started thinking, okay, let's think outside the box. Let's think how we can actually do a transplant without using a sibling or unrelated. And that's where the haplo transplant field had just emerged. People tried it in the 90s. It really failed miserably because people thought initially, okay, well, if we do a stem cell and we take the T cells out that causes the graft versus host disease, we can have a successful from a half match. But they found out how important the T cells are when they did that. If you don't give the T cells, which I think of it as you're sending the stem cells and you're sending somebody to defend it with it, which is T cells. The T cells defend it and keep it a check so that it stays there and it helps it grow and prevent infections. So the T cells were important. So we thought, okay, how can we do it? Then Hopkins group came up with this brilliant idea of discovering that cyclophosphamide, the chemotherapy that we use for a lot of other things, can actually target only the alloreactive T cells. So you can actually do a haplotransplant with everything. And then 2 days after you do a transplant, just give 2 doses of cyclophosphamide, and you only get rid of the T cells that cause graft versus host disease. So now, we can actually do haplotransplant, and we increased our pool for all. Now everybody can have a donor. Everybody has a parent, unless they're a doctor, but you can find their parent, and you can actually do a transplant for a lot of other people. But, like I said, you have to prepare the body to receive it. And the principles of preparing the body is you want to get rid of their disease if they have leukemia. But if they didn't have leukemia, you want to empty their space if they have a normal bone marrow, like sickle cell disease. But if they have aplastic anemia, you don't necessarily need to empty the bone marrow because they don't have anything there. So it depends on what disease you pick, what you condition the body to receive. You just prepare the body for the new cells to come and grow. And it just depends on what the disease is. So you can give high doses of chemotherapy if you have leukemia, or you can give low doses if you have immune deficiency. But still, the graft versus host and the host versus graft is still the main issue. And we have many ways to prevent it. We have many ways to treat it, but it's ideally is not to have it, especially if you have a non-malignant disorder. So we have everybody on immune suppression to try to suppress the cells and try to suppress the immune system so that it doesn't cause the effect. But it does happen every once in a while. So this is a complex that I'm not going to go over, but it's basically just to say that those donor T cells that come in with the bone marrow are the reason for causing graft versus host disease. And I talked about it a lot, but then people don't understand what it is until they actually see the pictures. And it can be really bad if you have stage 4. And what it is, what I like to describe it, and I've seen it only one time in my whole 10 years of doing bone marrow transplant, is that basically you're almost like putting a child in really hot water and then coming out very burned. And that's because it affects the skin as one of the areas where graft versus host, and it can cause bullae, and you're really almost like in a burn unit. That's the most severe form. In the milder form, you can get a skin rash. Also, the diarrhea, it can cause diarrhea to affect the GI tract. It can be regular diarrhea, but it can be like you're pouring out liters and liters of stool per day. So it's very significant, and it's not something that you can say, okay, it's just a skin rash, we'll be fine. It's a skin rash that can be really fatal. And then you go on, it can become chronic, and when you have a chronic graft versus host disease, it's almost like having another disease, like lupus or scleroderma, or like a dermatological disorders where you really have the thick skin. So it's not something you want to have, especially for children that are going to grow hopefully and have a long life. I mean, you don't want to have it for adults too, but. So the phases of transplant, we kind of talked about like the preparation, how we prepare the body, how we infuse the stem cells. The stem cells are infused in a bag. They're not a surgery, nothing. It's just you really get the patient, you give them the cells in their veins, and then you manage the post-complications in the long term as their immune system slowly recover. And basically, it's the waiting for these seeds that you had just implanted for them to grow. First, they have to repopulate to make themselves, and then they have to differentiate to make your immune system and your blood system. They first make your blood system, then they make your immune system. That process takes anything from 6 months to a year for the whole. I tell my patients, give us a year of your life for this. Dedicate a year. It could be less, but usually it's a year. You can go to school, you have to be under infection precautions, you have to wear a mask, you cannot be in daycare, you cannot be exposed to anything. So it's really, I don't want to say you want to be in a bubble, but it's almost like that for that time. But most of the time, by 6 months from transplant, most kids have already started to recover their immune system. And if they do, we start immunizing them again because you have resetted their immune system and removed all their immunization. So life after transplant, day 100 is an important day. It's a milestone in the transplant. Once you pass day 100, the survival improves and the risk of dying from transplant, it becomes less and less. And after the 1 year, we celebrate. You're 1 year out from transplant now. You're actually, I tell them, you're free. You can do whatever you want. And they're all like, we don't want to be free. We're like scared. And we want to still wear our mask. I'm like, nope. You can go to school. You can go back to your pediatrician. You can actually have your immunization. You're fine. You can just live a normal life. You still follow up with us because, we just gave you huge doses of chemotherapy and radiation and did a transplant and did all that. So you still can have any of these late effects. Depending on your disease. We check, and that's one of the things that we check throughout, lung, heart, eyes, depending on what kind of chemotherapy that you receive. So these late effects are followed in the long-term follow-up clinic. So this is not a transplant person only. This is all these people get involved in the care of a transplant. So once you have a transplant unit, everybody needs to get there. Cardiology, pulmonary, dermatology, everyone gets infectious disease. So it does take more than 6 hours to do a bone marrow transplant, unlike in Grey's Anatomy where they did it in one episode. So no, it takes a lot longer than that. So now where do we go from there? Now I talked a lot about the T cells, of how important they are, and that's kind of where the field is going. We're learning more about T cells and how important it is in treating cancer. We're trying to use our own body to treat cancer rather than using drugs, because that's the best way. If you can figure out how you can make your body treat your own cancer and trigger that process, then you can really succeed better than using all the side effects of chemotherapy. So now we have developed the cytotoxic lymphocytes that are actually, we put them in with viruses, we grow them, now they actually have antibody against the virus, and then we put them back into the patient who had a virus, and it goes in straight to attack the virus. So I was just talking yesterday to dinner about, we had a patient with EBV lymphoproliferative disorder about 10 years ago and today, and that patient 10 years ago ended up dying from the EBV, and today the patient received EBV cytotoxic lymphocytes and their disease were gone. So we're discovering a lot of newer things, cellular therapy related things that are cool, and they're been able to attack a lot of new things and help even improve the transplant. And the next field is the chimeric antigen receptor. It's not the CARs, but it's really creating chimeric antigen on the T cells to attack the leukemia cells without anything else. And of course, the field of gene therapy and graft manipulation, which is one of my research interests. So just going back, I know I don't have to go through them again, but now you probably know what to tell this mom about the donation, that it's fine and it's safe and it's not that hard. We understood a little bit about mucopolysaccharidosis and how transplant helps in these patients. And we understood about newborn screen. One thing I just forgot to mention here, when this mom calls and says, what should I do? I think the first thing I'll tell her, don't breastfeed and stay far away from infections until we figure this out. Not everybody who has a newborn screen positive end up having SCIDs. Actually, there's a lot of false positives. So just breastfeeding can introduce CMV. So we'll say avoid it until we know. And then the other thing we'll say stay away from infections until we know. Then once you go to the immunologist and they confirm it, then we can move forward. But it's not 100% if you're positive you have it. And then we learn about cord blood, and hopefully I convince you to donate cord blood or convince people to donate it. And then following a patient post-transplant after a year from transplant is really like any other patients. They can get strep throats, they can get fevers, they can get rashes. They don't necessarily need to relate it to transplant. They can be treated like any other. They still follow up at the long-term follow-up clinics and transplant. So if there is anything that's just to be vigilant of all the long-term effect that could happen. So just take home messages. Transplant is a procedure. It's not a disease. It's very highly complex, like I explained. Requires so much immunology thinking and so much different diseases that we treat. Cell therapy. Cell is the drug now. We try to avoid using medications and use cell to treat cancer and to treat diseases. And it's not one person's job. It's a multi-specialty. Everybody had to get involved and be on board. And it's the solution for a lot of diseases, but it also can cause another disease if you develop chronic graft versus host disease. And there's lots of research trying to prevent and figure out a way how to get rid of it. So thank you. I might go on. Any questions? You can ask about the Buckeyes too.
Is there an explanation for a high relapse rate in the identical twin transplant? Is that T-cell related?
Well, because they have the exact same cell. So the reason why we think they relapse is because it's almost that you're transplanting them with their own self. And the idea is that when you transplant somebody from a donor, you're giving them T cells, and as much as they are a match, they're still not 100% match. We check these 10 antigens now, or 12 antigens, but there's always newer things. So we think that the T cells that are infused with the bone marrow are going and attacking the leukemia cells. Because there was studies that shows if you actually transplant syngeneic, match-related, match-unrelated, and if you get graft versus host disease, you actually get better survival. If you do twin to twin, you get lower survival and more relapse. So they figured it's related really to the T cells that are infused with the bone marrow that help prevent the relapse, because they ongoing killing of the tumor cells. That's it. Thank you.
Thank you.